All right, let's dive right into this exhaustive explainer on brain abscess treatment. This is a topic where precision is absolutely everything, so we're going to break down the entire clinical decision tree step by step. We won't be skipping a single detail. Whether you're reviewing this for your own clinical practice or you're just really fascinated by neurology, this is going to clear up the entire protocol for you.
So, here's our roadmap for today. We'll be looking at 1. General brain abscess treatment, 2. The medical treatment controversy, 3. Predicting medical success, 4. Candidates for medical management, 5. Surgical indications, urgent threats, and 6. Surgical indications, complex cases.
Section 1. General brain abscess treatment. Let's start by establishing our standard baseline.
While every patient obviously needs a tailored approach, there's a specific foundation that always applies. Treatment universally rests on 3 main pillars. First, surgical treatment, which usually means needle drainage or outright excision of the abscess. Second, you have to identify and correct the primary source of the infection. Think about it. If you don't stop the leak, the ship is just going to keep sinking, right? And third, the long-term use of targeted antibiotics. You really can't skip any of these in a standard case.
Now, when we say long-term antibiotics, we are talking about a true medical long haul. We're looking at intravenous or IV administration for 6 to 8 weeks. And honestly, that's often just the beginning. It might be followed by oral antibiotics for another 4 to 8 weeks. But here is the absolute golden rule you need to remember. The duration is always guided by the patient's clinical and radiographic response, never just some set calendar date.
Section 2. The medical treatment controversy.
Before we even debate holding off on surgery, you've got to follow this rule. Secure tissue first, antibiotics second. Why is this such a big deal? Well, we absolutely need that tissue to isolate the exact pathogens, and you want to do this before antibiotics mask the evidence and give you a frustrating false negative culture.
But what if we just don't operate at all? Relying on purely medical treatment, meaning zero surgical drainage or excision, is highly controversial. This is especially true in the early cerebritis stage. That's the localized inflammation of the brain tissue right before a firm abscess wall is fully formed and encapsulated.
So why does medical therapy sometimes just fail entirely? It's actually fascinating. Studies have cultured living pathogens from well-encapsulated abscesses even after 6 solid weeks of adequate antibiotics. The failure happens because the capsule has a terrible blood supply, so the drugs just can't get inside. On top of that, the acidic conditions inside the abscess can literally deactivate the antibiotics. The environment itself fights off the medicine.
Section 3. Predicting medical treatment success. Medical therapy is most successful when we can confidently check 3 specific boxes. First, treatment has to begin early, right in that cerebritis stage before complete encapsulation happens. Second, the duration of symptoms should be 2 weeks or less, which really strongly correlates with being in that early stage. And third, we absolutely need to see definite clinical improvement within the very first week. If you don't see rapid improvement, medical management is likely failing. Size is also a massive predictor of success here. Abscesses successfully treated with antibiotics alone generally measure between 0.8 and 2.5 centimeters. On the flip side, cases that ended up failing medical therapy were notably larger, averaging about 4.2 centimeters.
Which brings us to a hard, definitive rule. If the abscess is over 3 centimeters in diameter, surgery has to be included. This is a clinical cutoff you absolutely must memorize. Above 3 centimeters, antibiotics alone simply will not cut it.
Section 4. Candidates for medical management.
Now, we do consider medical management alone in 4 distinct scenarios. First, if the patient has multiple abscesses, especially if they're small. Second, if the lesion is in a deeply inaccessible location, like the brainstem, where surgery would just be incredibly dangerous. Third, if there's concomitant meningitis or ependymitis. And fourth, if the patient is a fundamentally poor candidate for surgery. But here's a really important caveat. Even in poor candidates, a stereotactic biopsy under local anesthesia can be done in almost anyone with normal blood clotting. So getting that crucial tissue sample is almost always on the table.
Section 5. Surgical indications, urgent threats. This is the climax of our decision tree, when surgery is no longer optional.
Initial surgical treatment is immediately indicated when the brain is under critical physical distress. If a CT or MRI shows a significant mass effect where the lesion is literally shifting brain structures, you have to operate.
The same goes if there is evidence of spiked intracranial pressure, or if the patient's neurological status is severely depressed, meaning they're only responding to pain or they aren't responding at all.
Location completely dictates the danger level here. If an abscess is close to the ventricle, it is basically a ticking time bomb. It points to a really high likelihood of intraventricular rupture, which is a catastrophic event with drastically poor outcomes. You simply cannot wait around for this to happen. You must intervene surgically.
Also, if the diagnosis remains elusive, surgery is indicated. This scenario is actually pretty common in adult patients. If you don't know exactly what pathogen you're fighting, you have to go in and secure that tissue sample to find out for sure.
Section 6. Surgical indications. Complex cases.
Some types of abscesses are just structurally or biologically immune to a medical-only approach. You obviously can't medically clear out foreign material from a traumatic injury. Fungal abscesses have notoriously thick, aggressive walls that antibiotics and antifungals really struggle to penetrate. And multiloculated abscesses, which have multiple complex internal compartments, are physically just too complicated to drain on their own. Surgery is absolutely mandatory for all three of these profiles.
Notice the strict safety net we have to have in place. If you're treating medically, you must monitor the patient closely. If follow-up CT or MRI scans cannot be obtained every 1 to 2 weeks for whatever reason, you just can't safely rely on antibiotics alone. You'd be flying blind, which means surgery becomes your only safe path.
We also have to define exactly what counts as the failure of medical management. Any unplanned neurologic deterioration while the patient is on antibiotics is an immediate red flag. Similarly, if follow-up scans showed the physical progression of the abscess expanding toward the ventricles, medical therapy has failed, and you need an immediate surgical rescue.
Finally, time is our ultimate metric for measuring failure. If the patient has been on medical therapy and the abscess has actually enlarged by the 2-week mark, that's a failure. Or if you reach the 4-week mark and the abscess has shown absolutely zero decrease in size, medical therapy has failed. In both of these specific timelines, surgery is required.
So we've covered the rules, the exceptions, and the urgent indicators precisely as the clinical protocol demands. But as you master this textbook approach, I want to leave you with a thought about the future. As pharmacology advances with increasingly sophisticated and targeted antibiotics, will this strict 3 centimeters surgical cutoff remain the gold standard forever? Or will we eventually find a way to safely dissolve larger abscesses without ever picking up a scalpel? It's a fascinating area to watch. Thanks for joining me on this explainer, and keep learning.